So I want to welcome everyone to our closing of our 2024 conference on adolescent health. I'd like to introduce our final featured speaker, Tolulope Sonuyi, refusing to ignore the cycle of preventable death and injury from community violence among Detroit's youth. He's part of the Health Center Violence Intervention Organization known as Detroit Life, and is a valuable everyday, also known as DLive. DLive designs and delivers upstream health-centered solutions directly geared toward advancing the health outcomes of one of Detroit's most marginalized and misunderstood populations. Recognition for his work with DLive has included the Cranes Health Hero Award and Emergency Medicine Physician of the Year by the Michigan College of Emergency Physicians. Please welcome Dr. Sonuyi to the stage.
Hey, all right. All right, so interestingly, how I can move this thing. All right. Y'all, thanks for having me. Appreciate it. It's an honor to be here with you all. You all okay with me moving this podium? Is that okay? Okay. I don't want to disconnect anything as I roll it. Okay. So just in case as I move around, up just a little bit like this. Yeah.
Artwork.
Yeah.
Round two, right? They're like, that girl keep knocking on that artwork.
So I missed some action earlier, huh? Okay. Yeah. No, this is good. This is good. All right, y'all. Pleasure to be here. Thank you all for having me. Thank you to everybody who's presented before me. Some great sessions that I saw out in the lobby. And again, thank you for the warm introduction. It's an honor to be here, truly. So as it was said, my name is Tolulope Sonuyi. Again, I serve as the founder leader for Detroit Life is Valuable Every Day. It's a health-centered violence intervention program that's focused on intervention and prevention for community violence for our young people who've been impacted by violence. And so we're going to talk a little bit about several things today and try to Okay, yeah, there it is. Applying the critical lens, right? Applying a critical lens to the intersection between of adolescence, community violence, and health. This next slide here is just the obligatory objective slide. Okay, not too important. So by show of hands here, just so that I know who's in the room, I always want to know who I'm talking to. I know there's some people online, but in terms of who's in the room, how many, I know I'm at an Adolescent Health Initiative conference. And so how many social workers do we have in here? Okay. How many high school educators or middle school educators or teachers? Okay, excellent. Public health professionals? Okay. Nurses? All right. Physicians? Okay. And last but certainly not least, and perhaps most important, what about our youth? How many youth do we have here? All right. Okay, excellent. Am I missing anybody? Oh, everybody was represented? Okay. All right, very cool. University professors, just like university? Okay, got it. All right, so again, thanks for having me. And so I always want to know who's in the room. And again, I work as an emergency medicine physician in Detroit, on the west side and on the near east side as well. Let's go ahead and get started. I want you all to walk with me just for a little bit, okay? These next stories you're about to hear are real stories, real life, real things that have happened. Sonny Grace Hospital is perhaps the busiest hospital in Detroit, for sure. And unfortunately has the dubious distinction of seeing the highest percentage of penetrating trauma in the state of Michigan. And so these stories come from there. Probably around 2016, 2015, there's a 20-year-old male who came into our emergency department. He was stabbed in the chest. It deflated his lungs, right? The medical term we call that is a pneumothorax. So there was a deflation in his lungs. He survived. We were able to take care of him, give him a chest tube, and we were able to discharge him in 24 hours. Just 2 months later, that same individual would return back to our emergency department. Only this time he had a body riddled with bullets to his chest. And despite our most valiant efforts in resuscitating him and cracking open his chest, that young man would succumb to his injuries. I want you to meet Johnny, a 17-year-old male. His first interaction, as far as I was aware, with our trauma center was when he got punched in the eye and sustained a left eye laceration. As you can see here, 2 years later, he sustained a gunshot wound injury to his right leg. It missed the bone, and he had a soft tissue injury. You might hear the term like a flesh wound. 3 years later after that, he would come back to that same emergency department. Only this time the bullet hit his bone, and he required surgery. Each of those times, we gave him expert medical and surgical care, right? Bandaged him up and sent him right back on his way back into the community. After he had this open fracture at the age of 22, he would return back 3 years later, only this time with his body all stabbed up. This time he actually had to go to the OR, and he was in the hospital for about 2 weeks, where they had to crack open his chest and his abdomen in the OR, and he survived. When you think about that, from the ages of 17 as a young man, young teenager, to 25, that's 8 years of recurrent injury that this young man was having, right? And you can imagine each of those like a flare-up, like a violence flare-up. And I want you to think about what was going on in this young man's life in between the ages of 17 and 19 and 19 to 22. You to meet Tony. Similarly, his first interaction and interface with our hospital was at the age of 15 when he was punched in the eye with brass knuckles. 3 years later, he was out of town and got shot in the head. Took care of him, he survived, and he was sent home. 4 years later after that, multiple gunshot wounds to his chest. Fortunate kid, a blessed kid, he survived that. Was in the hospital for several weeks. A year later, he would find himself incarcerated. And in one of the hospitals where I work, if there's any issues with any of the folks who were detained at Wayne County Jail, they'll bring him into the hospital for care. He was brought in because he was in a fight while he was incarcerated and had an injury to his lip. And just 2 years later after that, he got shot in both legs. 10 years, right? 15 to 25, 10 years of recurrent injury, this cycle of violence. And if you notice even with Tony, right, these are fictitious names, pseudonyms. In the previous slide, each injury was worse than the previous, right? There was an escalation in the severity of the injury that we saw. Jason, 9 years old. I think you all are getting the trend now and the idea. Came in for an accidental injury at the age of 9. 2 years later, he sustained a physical assault and had multiple bruises over the body. And you can see what happened over the next 2 years, ultimately resulting at the age of 15 with a gunshot wound to the leg. And unfortunately, at the age of 16, he was shot to death. So I want y'all to sit with those for a minute and think. Were these opportunities for intervention during each of those times when they were coming through the trauma centers and interfacing with our health system? If we had the opportunity to press a red button and provide an intervention at this critical time, would we? Could we? Was it our obligation as health providers? So let's dive into a few things. Like I mentioned, we're in Detroit, commonly known as the murder capital. Very frequently in the top 1 to 5 in terms of murders per capita for cities greater than 200,000. And unfortunately, it's been consistent as the leading cause of death for people ages 15 to 34 in the city of Detroit. And that's not unlike some of the statistics that we see across the country for African Americans. Right? As many of you all know, if you're from Michigan particularly if you're familiar with Detroit. It's a city that's approximately 80% African American. This was a special news series that came out in 2014, put out by the Detroit News. I encourage everyone to read it, called Surviving Through the Age of 18 in Detroit. The primary takeaways were this. Number one, children are dying at a rate in Detroit higher than any other city in the country, right, when this came out. And the leading cause of death for the young people ages 0 to 18 was infant mortality. And that was the highest in the country, tied along with Cleveland. The second leading cause of death for young people ages 0 to 18 in the city of Detroit when this paper came out was violence. And so these two photos were taken from that article where they talk about, again, Detroit being a city that has among the highest frequency of premature births in the country. There's a lot of efforts going on right now to combat that, and some of y'all may have heard of that, and some initiatives out of the mayor's office and Wayne State University. And again, just driving home this point around leading causes of death for African Americans and the Latinx community. This is across the country, put out by the CDC. Now, if you weren't looking at this and we were just considering all ethnicities and all cultures all put together, typically the leading cause of death when you talk about people ages 15 to 24 is what? Car accidents, right? Yeah, car accidents, that's sort of like the risk-taking phase that folks are in, diving, motor accidents, things of that nature. But when you're looking at it for these ethnicities here, you start to see that disparity, right? Where homicide is the leading cause of death, and it dwarfs the percentages when you look at what comes in second. Right, so we're not only dealing with the public health crisis, but we're dealing with something that disproportionately affects our African Americans and Latinx communities across the country. And one thing that's important to remember that shocked me when I was going through this stuff was that for every one fatal injury that we have, right, across the country, there's 100 non-fatal injuries, which means that trauma is alive and vibrant and breathing and walking around us and among us everywhere. So think about that. Next time you hear about somebody dying, there's 100 other people that got shot that are living with that trauma. And so we know what the one looks like, right? When people die, the memorials on the corner, the T-shirts, right? The walks, the vigils, all that. But we don't often hear about the voices of the youth and those folks who've been impacted by violence. I was able to peek in on a breakout session where they were talking about pain. All right, great job. This is a young man who was shot. I can't get through I can't sleep. I'm having pain, even though I know it's not really hurting. A mother coming in and advocate on behalf of her child. My baby needs help. He can't sleep. He's having nightmares. He doesn't want to leave the house. And then there's just raw and real emotion from somebody who's been shot. I want to get back at him. I just want to kill the person who shot me. And perhaps some of the most chilling, the normalcy. Ever since I was 14 and I saw my close friend killed in front of me, violence has just been normal. So this has an impact across our communities. We're talking about premature death. We're talking about premature disability. We'll talk a little bit later, but you can see about the destabilization of families. The wealth that's extracted and the potential that's extracted from our communities when our young people are injured and when they die. And not to mention the societal cost when it comes to mass incarceration. And the takeaway of this is that it costs a lot, right? It costs a lot. It costs a lot to take care of people in the trauma center. There's lost productivity. Youth violence costs. And so if the previous things don't move you to act or care or advocate, perhaps just being fiscally responsible will. So I want us to take a step back. I know that's kind of heavy at the beginning, so hopefully this lightens it up just a little bit. Think about the 80s and the 90s, the zeitgeist at the time. I know we have people across like different eras here represented. different ages. But in the 80s, right, you had, Beverly Hills Club. You see the shirt, that was Mumford High out in Detroit on the west side, not too far around the corner from where Sinai Grace is. I know you're probably familiar with that, Dana. Oprah, Ronald Reagan, all right, The Simpsons, Arsenio Hall shows and all that. Show of hands, people familiar with that? Remember that? Some people are, I might make sure I'm in the right room. All right, all right. So 80s and 90s, I want us to think back there, right? Here's what was also going on in the 80s and the 90s. We were getting tough on crime. That's what our politicians were doing to really have that political cachet and show that, hey, you know what? We're going to do something about what's going on out here. This crack cocaine epidemic, this gang and street epidemic, heroin, all these things. We're going to get tough on crime. We're going to roll out this war on drugs. We see how that is going. Want to privatize prisons and have this big push towards mass incarceration. Broken window policing. Anyone heard of broken window policing? Absolutely, right? You're going into the areas where there's blight, where there's socioeconomic distress, looking to find stuff, because we're going to lock people up and make our communities safer. Right? Mandatory minimums, gang injunctions. So if you're gang affiliated, right, and you have something that goes on, you get an enhancement. So that's going on in the 80s and 90s, right? Crime bills and things of that nature. But here's what was also going on in the 80s and 90s in our trauma centers across the country. In New Orleans, where trauma surgeons and emergency docs and things, people in the trauma centers were noticing something. They was like, hey, you know what? This person that I took care of, like Johnny, that we saw earlier, they're coming back again 2 years later. They're coming back again 2 months later. What's going on? Same thing in DC, this recurrent intentional injury that people were seeing. Sorry. Jackson, Mississippi as well. Trauma as a recurrent disease. And last but not least, here in Detroit. I say here, like I know we're in IFC or Ann Arbor, but yeah, y'all get my point. Urban trauma, a chronic recurrent disease. We're going to look at this a little bit closer. So this was a study in the early to mid 80s where they looked at people who came in through the emergency department for violent injury. And they followed them out to 5 years. And what they found was this. Out of all the people that they recruited into the study, and it was roughly a little over 500 people, when they looked at what happened to those people in 2 to 5 years, 44% of those individuals would come back with a repeat injury. 44%. That means for every 10 people that are coming through the emergency department with an injury, almost half of those are going to come back again with a repeat injury. And the time range in which they found that they were coming back was within 2 to 5 years. Most of them will come back within 2 years. So it heightens the urgency, right? It heightens the urgency of having critical, timely intervention in this space. And so they talked about that as trauma recidivism. A lot of times we hear about recidivism in the carceral system, right? But that term certainly applies when we're talking about chronic recurrent disease. And so, our communities in the CDC, Department of Justice, right? We have a push now in terms of understanding community violence as a public health issue, as a medical issue, right? Everywhere from internal medicine to the American Public Health Association, DOJ, right? More and more, we're seeing institutional awareness around community violence as a public health issue, as a medical issue. And again, this is Healthy People Initiative 2030. And so that is good. We like that, right? There's a change. That's definitely a departure from what we've seen with the tough on crime stuff. And if we are seeing this, if our medical communities and institutions are telling us that, hey, you know what, this is a public health issue, this is a medical issue, then perhaps now we can start looking at some of these things that come in and start reimagining and reframing how we interface with them, right? So no longer are they missed opportunities, but they're opportunities for intervention, right? And we certainly have a history of having done this before in the past, right? There's a lot of tobacco cessation in our health centers, right? We have stroke centers, chest pain centers. all things that are predicated upon intervening at a critical time. All right. And so pardon some of the medical stuff here, but I'll break it down just a little bit, right? And so we, historically in our institutions, right, the first thing describes a mini stroke, right? So if you have somebody that having this brief weakness on one side of their body or any slurred speech, right, that's important because if we don't intervene at a critical time, that could progress to a massive stroke or a massive brain bleed. Similarly with chest pain, somebody comes in and they were shoveling snow at night, they had chest pain, that person has to go into the hospital, right? If they're in the 40s, 50s, hypertension, diabetes, things of that nature, because if you don't intervene, that person could possibly die from a massive heart attack. Same thing with diabetes as well, right? Somebody who's kind of like lightheaded and peeing a lot and eating a lot and super thirsty requires acute, drastic intervention. And so we can see from some of the previous slides here that now we have to start looking at interpersonal violent injury the same way. Because what those previous examples showed us is this: if we don't intervene in a timely fashion, then people can suffer a very tragic fate. And so this study actually came out of here, where they looked at violent re-injury amongst youth out in Flint, Michigan. And what they did was they compared people who came into the hospital for an assault injury, and they matched them up with similar sort of like case control age and things of that nature for people who come in for, let's say, asthma or vomiting or something that's non-assault, non-trauma related. And they followed them out for about 18 months. And what they found is you may deduce that the people who came in for assault got injured at twice the rate than the people who didn't come in for assault. But I think the most important takeaway is this: the people who came back who had a repeat assault, most frequently it happened within a 6-month period. So this is an emergent issue. All right? So when these things arise, this is an emergent issue because people can have a repeat injury and sometimes die from this. And so this is an important slide here, just to be aware of the predictive analytics that are associated with violent injury. First and foremost, the number one biggest predictor of violent injury is the fact that they've had a previous one in the past. And when I was starting this work, one thing that surprised me was the second bullet point there. Right? The frequency in which individuals who had a history of a mental health challenge or a psychiatric history and the risk that played in predicting future violent injury. The third bullet point, super important: witnessing violence or having been threatened with a knife or a gun. That young man or that young woman who perhaps they were threatened or they were robbed on the way to school. And in their head, they make a vow to never let that happen to them again. I'll never, ever let that happen to me again. I'll never be that vulnerable. And so from there on, I'm going to move different. Right? And again, some of these other things here. And so this next slide here comes out of UCSF, where, again, they're just sort of talking about some of the elevated risk factors and different risk factors that could portend the risk for future injury. And so, again, just to show again I think some of the sophistication behind this and the importance that some of these risk factors play in terms of people's overall health outcomes. So trauma and violence is a vicious cycle. And I want us to think about cycles because I think that's a recurrent theme, not only in this talk, but really in life. And so when we talk about trauma and things that we see in the trauma resuscitation bay, right, there's certain things that we have to do as health providers when somebody comes in and they've been shot and they're bleeding or whatnot. Let me put this here. This is what we call the lethal triad in trauma. And basically what this is saying is that you got to keep them warm, right? Hypothermia is cold. You got to keep them warm. You got to prevent their blood from becoming acidotic. And you got to prevent them from having bleeding, right? A bleeding disorder. And if you don't control either of those things, this cycle is just going to spiral into that person dying. All right. So this is like from a medicine clinical standpoint. And the point of showing you this is that we have interventions for this. Right? There's different approaches that we have to do this, right? We transfuse in a certain sort of methodical way that's been evidence proven. There's certain medications that we can give to stop this, to stop bleeding. We even staged the surgeries and things that they have just because some of the research has shown that, you want to maybe not fix it all at once, if you will. But when we think about the cycle of violence and some of those cases that we looked at earlier, there was really no interventions, were there? The intervention was sort of the standard medical and surgical care that they got, whether it's taking care of their wound, getting the chest tube, going to surgery, and what have you. There was no interventions for those young men. Oops, double microphone. And so, I think in my space, if you will, as a health provider and some of the people that are involved in the, in the hospital taking care of people, I think there's pretty much two reactions when you work at a space like Sinai Grace Hospital, Detroit Receiving Hospital. Number one is you can just be dizzy and dazed by all the stuff you see. You just push through it trying to get home, right? Because it's so crazy, it's so wild. You've been doing it for 10, 20 years. It's not going to change here, right? These kids aren't going to change. These neighborhoods aren't going to change. And you just try to get through it. Or apathy. The same apathy that some of the young people have when they talk about violence is just normal. I think we're subject to that too, right? This stuff is just normal. It's what we do. That's what we do. It's why I'm working here. I want to take care of people and see the stuff and get good training and take it somewhere else. I think this quote kind of sums that up sometimes, right? That sort of sense of defeat. We can sew them up, but we can't make them well. So when we do think about the cycle of violence, this is really what's happening, right? This is really what's happening when those young people were being discharged and we were sending them right back into the community to try to figure it out and to navigate their lives post discharge after treatment. I want you to focus right here. Right? The acute stress and PTSD that was happening in each of those lives, potentially, combined with their adverse childhood experiences or their history of childhood trauma, making for a tragic, volatile cocktail sometimes. And so being discharged and having those factors at play, and then what comes next? Either you're self-medicating, trying to deal with that trauma, trying to cope, trying to figure it out. Self-medicating, you're out with your friends. Maybe you have a weapon on you now, right? Because this is not going to happen again. You survive this. All right. And then the next sort of smallest little thing can kind of go from 0 to 100. And now you're in the retaliation space. And you either end up back in the hospital, or you end up detained, incarcerated, or worse, ending up dead. So I want to peel back the onion on this a little bit, okay? We're going to talk about PTSD and adverse childhood experiences. But just take a look at this, right? So I have the onion in the background because, again, we got to peel back the onion a little bit to kind of understand what's underlying all of this. So typically when we think about PTSD, we think about it in the combat space, right? Combat Army veterans, right? And I thought this slide really illustrated that well. People looking well, but they're a ticking time bomb. And when we think about PTSD, the National Center for PTSD put out this. People coming from Iraq and Afghanistan, 11 to 28% of people would eventually develop PTSD. From Vietnam, it was even higher. And for our general population, 8%. Should remember those numbers. Here we have this aerial shot of downtown Detroit. And when we think about Iraq and Afghanistan and Vietnam, what would people guess is maybe the rate of developing PTSD amongst civilians in places like Detroit, Flint, Saginaw, Ypsi? What would we think is like the rate there, right? 11 to 20% we said for Iraq and Afghanistan, right? 30% they found for Vietnam. What are some numbers that people would think for maybe some of the young people that we were talking about earlier? Okay, good, 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 good. All those numbers are right on target, right? And there's been several studies trying to measure it. Admittedly, it's a hard thing to measure, and we'll kind of talk about the why later. 47 to 80%, as high as 80% in terms of civilians who are living in the community that don't have the luxury of coming home and leaving Iraq and leaving Afghanistan, right? Because it's there. They live in there, right? They're living in these war zones. 47 to 80%. Again, you compare that with the general population, if you will, in terms of people who have not been impacted by violence, 8%. And so one of those studies was out of this level 1 trauma center at Grady Hospital in Atlanta, where they looked at approximately 60 people. And again, 75 to 80% of those folks reported severe PTSD symptoms. How many people heard adverse childhood experiences? Okay, good, good. That's what I'd expect at this conference. All right. So we're going to talk about that just briefly, right? So that study came out in about the mid-90s, right, out of Southern California, where they looked at tens of thousands of people. I want to say approximately 17,000, over 17,000. This is important, it was a roughly middle-class population. I think most folks had like a job, had degrees, they had health insurance, all that. Out of San Diego, and it was a collaborative study between the CDC and Kaiser Permanente Hospital, and they asked adults who had certain diseases and things of that nature to think back to their childhood between the ages of 0 to 18 around different kinds of trauma that they may have experienced in the areas of either abuse, so physical, verbal, emotional abuse, neglect, or household dysfunction on a scale of 0 to 10, right? Each answer, if you scored yes, was a 1. And it went from, like I said, 0 to 10. And what they found was this, in a nutshell: there is a dose-dependent response whereby the higher your score, the worse your health outcomes, right? The more sort of chronic diseases that you developed over time. Like I said, it went from 0 to 10. And one of the most important things is this: if you have a score of 4 or higher, that seemed to be a significant inflection point in terms of your risk for other diseases. In fact, when they compared people who had a score of 4 or more and then compared that to people who had a score of 0, the people who had a score of 4 or more had 2 times the risk of tobacco abuse, 7 times the risk of, I believe it was IV drug abuse, right? 12 times the risk of attempting suicide, and over 200 times the risk of developing communicable diseases such as sexually transmitted infections and hepatitis. All right. So it has a significant impact on people's future health outcomes. And again, one of the takeaways again from this is when they looked at these folks in that study, most people had at least 1 ACE score. All right. So it's not unusual to have an ACE score. But sometimes what the difference is the interventions and the buffers that people have to be able to respond to those. And so this slide here, again, just shows that the majority of toxic stress that people do have and its impact on the brain comes in the form of childhood trauma and ACEs. And the takeaway from here is that when you have normal stresses over a period of time, you're able to develop those normal sort of neural connections in the areas of the brain that are responsible for impulsivity and executive functioning. Whereas when you have repeated toxic stress, that development in those critical brain areas become compromised, and you're not able to build some of those connections there, right? And that's what that graph shows on the left of that picture. And just to take people there, I know we have all different stages in terms of exposure here. So this graph on the left just shows the different kinds of stress. Stress is normal, right? Stress is normal, stress is okay. There's the good types of stress, like getting ready for a talk, getting ready for a race, things of that nature, right? Get the stress, come right back down, everything is good, all right? The little adrenaline that you need to get through that moment. And then there's the other ones where, like, maybe you got into a car accident or had the death of a loved one. And again, that's a tolerable stress, particularly when you have the supports around you to guide you through that. But when you think about toxic stress, that's the stress that's in there every single day that doesn't go away. Right? When somebody's coming in and you are, subject to that abuse, or you're seeing these things that are happening to you every day, that's that toxic stress where you have, again, that constant sort of outflow of those stress hormones that are impacting the body and the brain. And when they looked at, this was a program out of Philadelphia where they do some similar work around violence intervention. And in the cohort of about 32 young people that they saw, the incidence of PTSD, again, there goes that number, 75% for the young people. And the average ACE score, about 50% of them had an ACE score of 4 or more. And so we've talked about PTSD and ACEs. And so bringing us back to this slide, when you look at this, the diagram in the middle, all right, the takeaway is that PTSD and the mental health of our young people, as well as their history of childhood trauma and the impact that it has on brain development, all those things play an important role in perpetuating the cycle of violence. And so it's important and critical that we understand that, so we understand what was going on in those young people's lives that we described earlier when we opened up with this talk. And so as a result of this and understanding some of this science and some of what's happening clinically and some of what's happening in the community, DLAB was formed. Okay. And so I started this back in 2016, but it didn't just start out of nowhere, right? Because it took a lot of understanding, learning, listening, and understanding what was needed. And so it's called Detroit Life is Valuable Every Day Violence Intervention Program, a violence intervention and prevention program. And we are in our 8th year. We're in our 8th year of doing this work. Thank you. I heard a little thing. Yeah, and so yeah, we'll talk about that. Certainly hasn't been easy, but it's been but it's what was needed. It's what was needed there, right? As you guys saw from those previous slides there. And so just a very quick schematic here. Essentially, we're able to kind of connect with folks at this critical time. We talked about this missed opportunity in that timer, right? So those are critical times when this acute injury happens. And like I said, I work in the trauma center, and so we're able to connect with young folks and people who've been impacted by violence and take them out of this gravitational pull in this cycle of violence and get them over to more of like a wellness hub, right? In terms of all the support and things that are needed in order to be able to address what's been going on. And again, stem that cycle there. You can't prevent PTSD. I can't prevent that. I can't prevent the childhood trauma that somebody had when they come and enroll with us, right? But perhaps we can stop the things that are downstream from that. And so in this next part of the talk, I just wanted to take some time to share with you all some of the learnings and insights and strategies that we've learned from our best teachers, right? And those are our DLAB participants. And that's 2 of them in the back over there. We're going to start with Mike. Title of this slide is Through a Child's Eyes. So a guy in his early 20s. Mike came to us after being shot several times. He was in front of a house with some of his friends. It wasn't his house where his address was at, though. See, him and his mom had a suboptimal relationship where there was some toxicity there. So he wasn't allowed to be at the house. And so you had a guy who was going from house to house, couch to couch, trying to find stability and somewhere to live. And at this place where he was when he got shot, he talks about the lifestyle that was being led at that place and some of the activity. A lifestyle that he says that he was born into and introduced to by his father. See, his father has a history of being incarcerated as well. And unfortunately, Mike was unable to escape that gravitational pull himself. And he was in and out of jail and juvie throughout his teenage years and early adulthood. In addition, we happen to find out, again, that he wasn't employed at the time. And while I was talking to Mike and building with him and getting to know him, one thing he shared with us, actually not in that session, but down the line, was this. Before the age of 10, he witnessed murder. I'm going to say that again. Before the age of 10, he witnessed murder up close and personal, live and direct. So we got to think about what was the impact that that had on him and that exposure to violence. And it's part of the reason why I included this this picture up here from Mr. Nasir Jones. When his debut album came out, and he put a picture of him as a child when he described his environment in Queens, New York, as a young man navigating that environment and understanding the importance of what happens to our young people in their environments and their communities where they live, and how that affects their trajectory down the line. We didn't know this about Mike. No one knew this about Mike when he was being treated in the hospital. Oh, man, I need y'all to go talk to this kid, man. He's causing a ruckus. Him and his mom are in there beefing and not getting along. And so Mike, again, he talked about being exposed to violence at the before he was 10 years old. And I think this article here really drives that point home. I'll let y'all see the title there. Basically, what they looked at was this. This was at a Midwest sort of mental health facility, I want to say in Illinois. And they looked at folks who were showing up there for anxiety. And they looked at folks who had sort of severe anxiety, and those are folks who they described as having somatic symptoms. So somatic meaning, again, things that were impacted their body and how they were feeling when they were feeling restless, when their heart was racing, they were having chest pain, stomach pain, headaches. And what they found was this: the association that they saw between people who had a history of childhood trauma and the severe anxiety, it was exposure to community violence that was the mediating factor, right? And hence the triangle there, right? So there's that CVE, community violence exposure, sort of mediated that relationship between childhood trauma and the people who were showing up with these severe symptoms of anxiety. And one of the takeaways or suggestions from the study was that, as if the ACEs screening thing that we talked about wasn't enough, they were like, you know what? In order to be able to really robustly capture what's really happening in some of our specific communities and marginalized communities, and really community violence exposure is not just relevant to Detroit. It's not just relevant to Flint. It's relevant really across the world, right? And what they said was, hey, you know what? We need to add community violence exposure as its own separate category on our ACEs screenings for assessments in order to be able to, again, robustly capture some of the things that have been impacting our young folks so that we can identify, as it says in that next, that bottom bullet point, the toxic stress that affects the physiological responses in children. By the way, I think one thing that's important, community violence exposure was defined by 4 things. Number one, you could be community violence exposure was defined by either hearing about things through media reports or hearing about things just sort of like firsthand. Maybe it's being talked about at the dinner table or what have you, or you hear about a neighbor talking about violence that happened down the street. Number 3, in Mike's case, witnessing it firsthand, seeing somebody get beat up, get jumped, get stabbed, get shot. Or number 4, experiencing it yourself and being shot or stabbed or beat up or jumped. So those are the 4 types of community violence exposure that they looked at. And so, as we can see with Mike, and as we can see with this quote from another DLAB participant, the reality is that a lot of our young people were experiencing trauma before we ever saw them. Right? Before they ever came in front of me, before they ever got enrolled in DLAB, they were already bleeding, as he said. Before we got shot, we were already bleeding, and we're still bleeding. And so with this understanding, the way that us as this program, as this hub, as this sort of collective community for our young people, working to provide the support and care that they need in this acute and long-term phase, we have to be aware of this, right? We have to be aware of some of the decision-making that they're going to make, right, as a result of what's happened. We got to be aware of like the milestones in terms of our expectations versus reality. Because again, they were already bleeding before we got to them. All right. So just a few of the areas that that were impacted when we talk about Mike and a few other folks here, right? Number one, he was in front of a house that I said, right, he wasn't living at, right? So housing insecurity is a huge thing, right? Where we have young people where either housing insecurity, right? And there's a range when we talk about housing insecurity. You could be couch surfing, house to house and things of that nature. Mom's kicked you out, pops kicked you out, grandparents, right, don't want you there anymore. You could have rental strain. We're just hard making rent from month to month, so you're always behind. And so you're going to take some chances to try to make rent, or just straight up homeless. And we've seen all three. And sometimes it's a cause, something that was there before the violence happened, or sometimes it's a result of the violence, right? We've had young people who've been injured, and all of a sudden you've been injured. Parents don't want you back home. Why? Because you're a target. House is getting shot up, right? You got to go. You got to go. You're not welcome here. Nobody wants you around. You're a target. You're attracting bad energy. So as a result, on the DLive side of things, right, we have to design and come up with solutions and things of that nature to address this critical social determinant in terms of the different ways in which housing insecurity shows up for us. Young people, again, the pathway towards incarceration. And so our health justice partnerships in the city of Detroit are incredibly important. Right? Working with like-minded people in the legal space and lawyers and what have you, right? That understand that mass incarceration is its own social determinant of health and does nothing to help with stemming the issue of violence, especially like the public health issue of violence. And so working with our young people and working with our community partners to stem the tide towards incarceration. Ta-Nehisi Coates' book, in which he describes talking to his son and helping his son, the advice that he gives his son in terms of navigating the world as a young Black man in America. We talked about some of the individuals earlier where talked about being born into a lifestyle, some of the things that they were introduced to by their father. We had one young man who talked about when the first time he met his father was at the age of about 11 or 12, and the things that his father laid out in front of him in terms of what he was doing, thereby introducing him to the drug game. Or perhaps some of the advice that some of our young people never got. And so as a result, what we've worked to do is work with some of our partners in developing a fatherhood initiative to talk about some of those challenges, right? Because I don't think I mentioned it earlier, but Mike was a father. He is a father. He has his own children. What's he going to teach them? What he knows. And then this next one here, the intersection between community violence and education and some of the challenges that come about as a result of that. And we'll talk about that a little bit further. I want to take a quick moment just to talk about social determinants of health. I know everyone here is mostly familiar with them, correct? Yeah. All right. So the factors in which we age, live, work, and play that determine our sort of outcomes and well-being. And one of the takeaways from this is, out of the different factors here, this is, again, from some of the healthy people stuff, where they looked at education and economic mobility, employment, housing, and all that stuff. The last one at the top, healthcare and quality, is actually the least important out of all of them, if you will, in terms of the least contributory. So all us health providers here and docs and nurses and things of that nature, we're really not that special, okay? Right? Because everything else is really more like 80% in terms of contributing to people's overall health and their outcomes. And education has this outsized impact on everything. And so we're going to focus on that just for a quick moment, right? The issue of education. And it may come as no surprise that a significant amount of our young people that we've worked with and that enroll into DLive have an incomplete high school education. And so I want us to understand the outsized impact that education has on people's overall health and their future health, right? Because it's going to determine where you're able to live, determine what kind of job you're going to get, right? All those things, all those things are going to be playing into somebody's health. And so when we think about community violence, it has an incredible impact on people's education. And hopefully this demonstrates this to you all loud and clear. This comes from the case of a young kid, approximately 15 to 16 years old, who was shot while at a park. There was a basketball game going on. And in working with this young man, there were some challenges for sure. And I think this quote from somebody from our mental health team encapsulates that beautifully. Can everyone read this okay? I'm going to read along just to for those who may not be able to. I was able to meet with Barry and his mother. Man, this is from our mental health, someone from our mental health team. I was able to meet with Barry and his mother. Barry's mom shared with me that he had an anxiety attack after the last court date when the shooter was left off. Barry was actually taken to the ER that day and was released a short time later. He's endorsing these anxiety attacks at least once a day. He's not sleeping at night and he's having flashbacks and experiencing full body shaking when thinking about the situation. He is currently not in school because he is unable to focus, especially while the social media taunts continue. And as I mentioned earlier, the shooter does not live far from the family home. Oof. So you get this. The first thing and first plan of action, the first priority for this kid and the family is not getting back in school, right? As you can see from this, there's a host of things that we have to contend with and to work on, right? Issues of his immediate safety, right? Challenges that his mom is now facing as she's experiencing the vicarious trauma. Right? This really calls into and really illustrates what we talked a little bit earlier about with those somatic symptoms and what he was having with the full body shaking. All right, so we're talking about housing, we're talking about relocation, we're talking about the mental health support, and all these things that need to be addressed before we could even get to talking about school and education, something that's been interrupted all because of what happened at the park. And so again, it's representative of what's required in order for us to recognize, advocate for, and create a plan of action. And trying to do this is it's arduous. It's an arduous task, right? It's an arduous task. When community violence interrupts and disrupts somebody's educational process, trying to recover that is incredibly challenging. We had a case with a young person who, when he got shot, again, it not only impacted him, but it impacted the whole family. And so the stress of that caused his mom and the economic challenges that she was having. And then trying to advocate and get this young person back into school. But they don't want it back at the school. Right? Some stigma regarding that comes with this, right? Sometimes suspensions that come with this. And so some of the advocacy and the innovation that we had to do to try to find what's the right sort of learning environment for this young man who's had his school sort of process interrupted. And how do we create sort of like a customized strategy and solution for him to be able to kind of continue on with his education so he's not left to fall back into those cycles of poverty and injury and trauma. We had this happen with a similar case with another individual as well. And so those are some of the things that we have to navigate. And in fact, we had one young man, again, in terms of trying to get them back into school, where it was such a challenge that we've had people out of school for over a year, sometimes over 2 years. And so a lot of times what ends up happening is they have to go to a special sort of GED or high school sort of program, right? And to make something sort of individualized for them. And then you deal with all those challenges as well. And then you're out of school that long, and you start making decisions around, you know what? I think I'd rather just work and try to make some money than go to school. So the cycle continues. All right. But again, these efforts do have solutions and there's breakthroughs. And so we have one case in which, not only were we able to get the young man back into, again, not the traditional school that he was in, but a GED sort of high school diploma training program. And the cool thing about it was this, is that his mom, I saw earlier about people involving the parents and things of that nature. His mom was like, you know what? I'm going back to school with him as well. I'm going to get my GED as well. And so they're in school together. And again, when we're looking at the advocacy around education, okay, there's a lot of things that are hidden beneath the surface, right? And some of the things that we've learned from our young people is that, you know what? There's an incredible amount of learning disabilities that we see amongst our young people who've been impacted by community violence. And trying to sort of get that diagnosis and figuring it out has its own challenges. When you start thinking about the neurocognitive testing that's required, and the huge wait list that may be at a University of Michigan or Wayne State University in terms of trying to get somebody testing. Right? But we don't have that sort of time when we're working with our young people. Right? We're talking about life and death. We need fastness. We need quickness. We need motion. All right. And if you can't go to one of the universities or get something like that, then you have to get some private testing. And oftentimes that cost is a barrier. Try to get that done. So you can see some of the challenges there. We've learned about a lot of our young people having a history of having IEPs and these individualized education programs that they had while they were in school at some point. But try asking somebody who's been sort of disconnected from school for about 18 months or 2 years, and maybe even when they were going, there was maybe some, some absenteeism, and trying to get a hold of those. Right. And the impact of and the reason why you would want to get a hold of those is you're trying to customize new sort of solutions for them to continue on their education. Those are going to be critical and important to understanding how to show up for them and provide them the appropriate education that they need. And so those are some of the challenges that we run into as well. One of the great things that we've seen with that is that when you are able to get it, you are able to sort of develop some solutions and strategies for our young people to continue on with their education. And in fact, we did so in one case with somebody who was in their mid-20s and had been disconnected from school, but in learning about some of their learning disabilities and the fact that they had an IEP, we were able to do the advocacy for them to be able to allow them to facilitate their ability to get their driver's license. Right? And so we created specialized materials for them to be able to pass their driver's written test, their written driver's test after being unable to pass it about 3 or 4 times, and the appropriate sort of testing conditions that they required at the Secretary of State in order to be able to get their license. Because now they can get a license and get in a car and drive and start to be self-sufficient in that space. So we'll skip over this slide. Sort of talking about just chronic stress. And one thing about violence, hopefully that we've learned and seen, is that it's predictable. We talk about predictive analytics, and when things are predictable, they are preventable. And this quote came out of one of the co-authors for the ACEs study that we talked about earlier. And they're talking about that from the standpoint of adverse childhood experiences, because again, the higher that number was, you started developing diabetes, hypertension, and things of that nature. So just like those, violence is a chronic disease, and it is indeed preventable. Some of the goals, again, in terms of the mission of DLive, and again, we're trying to advance the health outcomes of young people who've been impacted by violence. And we go upstream in doing a lot of this, right? Transportation, housing, we talked about education. Mental health is a core tenet and a key aspect of what we do in terms of executing and carrying out our mission. It's a big team effort. It's a big team effort, and blessed to be able to work with the people that I do in terms of making this thing happen. And we wish it was easy, but it's not. Right? It requires a lot of work, requires a lot of iterations, and again, the solutions really happen at different levels. Right? They happen at the individual level, community level, all the way up to policy. And we've been fortunate enough to be able to create some impact at each of those levels, and we continue to do so with the help of our community and with the help of our young people. And I want to leave us with this quote here. This was at the end of that study that I talked to you all about earlier, where they talked about the trauma recidivism in Detroit. That was about 44%. And the authors talked about this at the end, and they said, hey, you know what? We're here today, we're talking about violence, so forth and so forth. And it's sad, and it's heartbreaking, and so forth and so forth. But like I highlighted at the beginning, hopefully we can do something to intervene in this cycle and put ourselves out of business. Thank you all for listening.
Okay, does anyone have a question for our speaker? Or do you just want to breathe? Take that in. That's also fine.
Hi, thank you for this great presentation and for the great work that you guys are doing. This is probably too early in the process, but do you have some outcome data or participants? Like where are they and how long are you going to follow them? And
What
do
was
they
the
come?
second word you said? I know
No,
you said
real
outcome data.
outcome data
Yeah.
for participants and how long you follow
Yeah,
them.
yeah, yeah. No,
What are your plans for the
absolutely,
future?
absolutely. So no, we've been fortunate. Like I said, the historical sort of re-injury rate in the city of Detroit, and we sort of seen that um, not only in the 80s from that study, but also an updated study that I did from like with data like in the 2010s, still about 44%, right? But with the people, when you have an intervention such as we've had, right, in terms of working with over 200 individuals, right, we've had a recidivism rate of less than 7%. Yeah. And to your question in terms of how long we follow them for, yeah, we don't ever stop following them. Yeah, we don't ever stop following them. Understandably, with the young folks that we work with, things can be transient. Some people can fall out of contact and things of that nature. But yeah, for the ones that we're able to sort of like follow up and see, we've been very fortunate and pleased with the impact there. So yeah.
Thank you for your presentation. I'm curious about some of the logistics as far as when you meet somebody in the trauma center, who is that link between them and the DLive program? Where does the DLive program function out of? And then like the $1 million question is, where does your funding come from?
Yeah, no, absolutely. So yeah, logistically, it happens at a lot of different levels, right? We work closely with all the different teams in the hospital. Whether it's like, our social work team, our trauma team, we are there. So we have office space there on campus. And so we're able to be aware of like when people arrive and being able to connect with folks at the bedside. And everyone on our team is equipped to go and connect with somebody at the bedside, right? Whether it's me, whether it's somebody from our mental health team, one of our engagement specialists, everybody's equipped to be able to connect with somebody at the bedside. And we've been fortunate enough, again, because of the work that we've been doing over time. Again, in terms of some of the hats that I wear, sometimes I'm actually there when somebody comes in. But we have other people advocating on our behalf, right? Whether it's whether it's one of my colleagues who might send me something, or whether it's one of our social work team, right? Shout out our social workers, other nurses, the whole nine. So it's a nice team effort. So we're on campus. And then for your last question, in terms of where does funding come from, primarily two main places, right? Which is philanthropic foundations. So we've been fortunate enough to be able to have some funding through our philanthropic foundations, as well as government funding, right? And so, there's been some increases around that talk at a government level. And so, I'm sure some people have heard about, what's happening with ARPA dollars and things of that nature. And so there's been some funding through there. So different levels of government as well as private foundations.
I have a question.
Oh, yeah.
Yes, first, thank you for this presentation. It's been really, really insightful. A lot going on, a lot to process. But I am wondering if you have or offer like a youth advisory board for the youth to give their feedback on and maybe and give their opinion on ways to improve it, and or a youth development for like progression for just different aspects of all kinds of youth development for them to get into the community.
Right. No, absolutely. So not formally, which is why I was like listening with intent at the session in the lobby around some of the different aspects that I saw around like the Youth Advisory Council. So not formally, but what we do is look to have different sort of opportunities in terms of like leadership development for our young people in terms of, so for example, I may have brought one of them here to sort of like speak with me, right? And to be here at this sort of talk. We involved them during some of our other community engagement and community health education things that we do, try to provide pathways for them to learn and become fluent in issues of trauma and mental health and things of that nature. We don't have a formal youth advisory council, but we have some sort of like youth peer leadership development type activity that we do. Yeah, definitely interested in thinking through around like youth advisory council sort of stuff. So I found that to be very inspiring from the different groups that I saw that were doing it.
Hi, this question. We talked a little bit about kind of the referral process when somebody comes in and you said
Yes.
it's kind of multidisciplinary. But then what happens after the discharge? Like what does the community outreach or like you said, the continued contact look like?
Yeah, they're with us. Yeah, it's with us. Yeah, so that we're working with them, intensive support, coaching, case management, the whole nine with us. And it could be 1 year, 18 months, 2 years, 3 years, as long as it takes. And so it's a long-term relationship that we have with them. It's just that initial contact is there. That's a sort of like initial on-ramp in terms of what we do. And then we're with them for an extended period of time in terms of their work with us and whoever we're connected to community-wise, that's able to do things. I think one thing that I didn't mention explicitly, but one thing that we've learned is that the community historically is not set up and customized to deal with this challenge. It's not, right? It's not set up to work with a young man who's got maybe 1 foot in, 1 foot out, who's been shot, trying to go to work, has a history of maybe being incarcerated, and you want to get him a job, and that's critical to their health, but they're not letting him get a job because it's not a thing, right? So there's a lot of innovation and advocacy and work that's required in order to be able to really create a culture of health in the community that understands our young people, right? And that's built and serves them, because historically it hasn't been there.
I just want to say thank you for this presentation first. And then I was wondering if there is a peer-to-peer aspect of the program, like any of the young people that have been through the program coming back and also providing support. And then also just thought of this question, sorry, I have two. You spoke a lot about young men, but I'm wondering, do you see young women coming through?
Yeah, absolutely. So to answer your first question, yes, we do have things where we promote that sort of peer-to-peer engagement, support, coaching. We had something that we hosted, I think, towards the end of last year, where we just had some of our folks who were veterans or had some more extended time in the program, or some of our folks who sort of completed or graduated from it, being able to provide some of that guidance and motivation to some of our young people. One of the big things that we've seen is alcoholism. And people sort of dealing with alcohol abuse and how to navigate that. And so being able to have some of our people who sort of shook that habit and being able to motivate some of our young people who are battling with that. And so we try to create, and find those connections to be able to have that peer motivation. And your second question, yes, absolutely we do. I'd say the breakdown is about, for our men, it's about an 80-20 split. You know what I'm saying? Yeah, it's about our 80-20 split. And so, yes, so we see women who have children, seen folks like transgender who've been injured as well, in terms of community violence. I think one thing that, an important note I didn't mention, we work with only community violence. And so we don't work with folks who've been, in terms of sexual assault or child abuse, or domestic violence. So those are things that we don't work with. That's not our specialty there. And oftentimes, because there was a sort of interventions and sometimes law enforcement involvement and all that stuff. And one thing about us is we do not work with law enforcement at all in terms of what we do in terms of our work.
We have time
So
for one more.
great question. And our women, I'll add this. Shout out to my guys in the program. But our women are some of our biggest achievers. You know what I mean? Just in terms of, I think getting to it quicker. And I think that has to do with a host of things, right? Maturity and some of the other obligations that they have. So shout out to our ladies for sure. They've taught us a lot.
We have time for one more question, and then we're going to have a quick closing remark after that.
Okay, so amazing presentation, and I wanted to ask, I want to thank you for bringing up education as a social determinant of health and really focusing in on that. I want to ask, what do you think is a correlation between the prison to school, the school to prison pipeline, in its impact on community violence, and also what are your thoughts on teachers and in the classroom utilizing special education as a way to just put Black men who are have behavioral problems into that program, but unjustly doing that to them, or incorrectly diagnosing them with an IEP?
Yeah. No, for sure. No, those are rich questions. And I want to make sure that I understand, and we should talk more afterwards, but that's a problem, right? I think that's a big problem. And if I could sort of wave a magic wand and have, other stuff and resources and things of that nature. I really think that's actually a key area where intervention is needed, right? In that sort of 5th grade, 4th grade, 6th grade, 7th grade, because that's really when you start to fall off the rails, right? And I think that we talked a little bit about those somatic symptoms, right? In terms of like the restlessness, and we talked about the impact of childhood trauma on people's their neural connections and brain development and their prefrontal cortex. That manifests itself as a certain way in the classroom, right? And when people aren't hip to that, and you don't know what's going on in the community, and that somebody's house may have just got raided next door, right? Or something else was going on, and there was people that were shot, and they were walking to school. They had to walk another way because this is taped off, and they're at school, and the teacher and you know what I mean, is not sort of like in tune with what's going on. You get exactly what you talked about, right? Misdiagnosis. Let's go in this sort of like special education program. You're going to get suspended. Someone's got a behavioral issue. I found that one of the things that we saw as I was doing some of our retrospective studies and research and stuff of that nature was that it was not infrequent for people to have a history of having been taken to like a children's hospital for like oppositional, defiant type thing, or, those sort of having that set of history. And so that's incredibly important. And I have seen some efforts in there in terms of, behavioral health presence and, recognizing this sort of thing in the schools as well. But I think it has a huge impact, right? Because once you take a kid off the rails and they get suspended and things of that nature, that's the pathway. I mean, that's the prescription for incarceration right there, and so it's a challenge, and it requires our full attention and scholarship and intellectual sort of creativity there for sure. It's a great question.